You thought your tonsils were a teenage problem, that they would shrink and quietly disappear as you left puberty behind. So why, years later, do they sometimes look or feel bigger? And if they are enlarged, can they really get smaller again? In the next minutes, I'll walk you through what enlarged tonsils after puberty usually means, how and why size can change, what you can safely check at home, and which steps commonly lead to real reduction, without promising any guaranteed outcome. If this topic feels relevant, pause for a second and subscribe so you don't miss the short demo later about safe mirror inspection and saltwater gargles. It's practical and non-invasive. Stay with me. I'll give clear self-checks you can do now, explain the likely causes, show the conservative things that often help, and outline when an ENT or your primary care clinician will want to investigate further. A quick, safe self-check, what you can and cannot tell from a mirror. Stand in front of a well-lit mirror, open your mouth wide, and say, "Ah." Use a flashlight or the light on your phone if the room is dim. This is a simple visibility check. It won't give a diagnosis, but it helps you gather useful information to share with a clinician. What to note? Can you see the tonsils on either side of the back of your throat? Are they symmetrical, or does one side look larger? Do they look smooth and swollen, or are there pits, white spots, or visible lumps? Is there redness or pus-like drainage? Does touching the outside of your throat, gently, reproduce pain? Do you feel a sense of a lump, difficulty swallowing solids or liquids, or new snoring or choking while asleep? Is there associated bad taste, persistent bad breath, or repeated throat clearing? What a home check cannot tell you: whether enlargement is due to simple inflammation, deep scarring, stuck debris and crypts, or a less common systemic cause like lymphoid disease or tumor. The precise size, millimeters, matter in clinical decisions, or whether the enlargement affects your airway while you sleep. These typically require a clinician's exam or a scope. Write these observations down: day of onset, how it felt at first, anything that made it better or worse, recent illnesses, recent antibiotics, reflux symptoms, allergies, smoking, and any medications. A short symptom log, dates, and a sentence per entry makes a clinical visit far more efficient and often shortens the diagnostic process. A brief primer: what tonsils do and what shrinking after puberty usually means. Your palatine tonsils are collections of lymphoid tissue that sit on either side of the throat. Think of them as part of the body's early warning immune network, exposed to everything that passes through your mouth and nose.
During childhood, they're relatively large because that's when the immune system is learning and adapting. After the teenage years, many people notice that tonsils become less prominent, a process commonly referred to as involution. But involution is not uniform. Some people's tonsils stay relatively large into adulthood. Others can swell again later. Size alone is not inherently dangerous, but what matters clinically is why they're enlarged and whether the enlargement is stable, fluctuating, or progressive. Common reasons adult tonsils are enlarged, and what each usually suggests. When enlargement is noticed after puberty, the likely causes fall into a few overlapping categories. Each carries different clues and different expectations for whether size can shrink with treatment. 1. Inflammatory enlargement from infection or chronic tonsillitis. What it is: repeated bouts of throat infection or ongoing low-grade inflammation make the tonsils swollen, tender, and sometimes red. Between flares, they may remain slightly bigger than before. Clues you might see: tenderness, sore throat that comes and goes, sometimes fever in acute episodes, or pus on the tonsillar surface during an active infection. Reversibility. Often this is the most responsive category. Controlling the infection and inflammation, with appropriate antibiotics when indicated, anti-inflammatory measures, and treatment of contributing conditions, can reduce size over days to weeks. Expect variability. Some people have recurring flares and only partial long-term shrinkage. 2. Reactive lymphoid hyperplasia, allergy-driven or chronic antigen exposure. What it is: tonsils can respond to ongoing exposure to allergens, irritants, or persistent antigenic stimulation by increasing lymphoid tissue. The tonsils become more cellular and can look and feel larger without signs of acute infection. Clues you might see: a history of allergic rhinitis, seasonal flare patterns, nasal congestion, postnasal drip, itchiness, or improvement with allergy control measures. Reversibility. With effective allergy management, nasal hygiene, and reducing antigen exposure, the reactive swelling can subside over weeks to months. Degree of shrinkage varies by individual. 3. Cryptic hypertrophy and tonsillolith-related prominence. What it is: the tonsils have natural pits and crevices called crypts. Over time, debris can collect and calcify into tonsil stones, tonsilloliths, or chronic scarring can change the surface so the tonsils look larger or irregular even if their true bulk hasn't dramatically increased. Clues you might see: recurring bad taste or breath, visible white or grayish stones, deep pits on visual inspection, or a sense of something stuck in the throat. Reversibility. Cleaning debris and treating inflammation can make the tonsils look and feel smaller. In some cases, an ENT can perform in-office procedures that smooth or reduce the crypts.
Structural scarring, however, may be less likely to reverse without targeted intervention. 4. Irritation from postnasal drip, chronic sinus disease, or reflux. What it is: continuous irritation from mucus dripping over the tonsils or stomach acid reaching the throat can keep tonsils chronically inflamed, maintaining an enlarged appearance. Clues you might see: chronic cough, clearing, nasal congestion, thick throat mucus, or heartburn and acid sensations that correlate with worsening throat symptoms. Reversibility: treat the underlying sinus disease, control reflux, and reduce postnasal drip. The tonsillar swelling often responds, but typically on a slower timetable, weeks to months. 5. Systemic causes and less common structural concerns. What it is: less commonly, generalized lymphoid enlargement from systemic infections, immune disorders, or rarely, neoplastic processes can involve the tonsils. Clues you might see: firm, rapidly enlarging lumps, associated weight loss, night sweats, persistent unilateral enlargement, one-sided, or blood and saliva. These warrant prompt clinician evaluation. Reversibility: depends entirely on the underlying cause. Some systemic conditions have good treatment options, others may require more specialized care. Key clinical distinction: soft and tender versus firm and painless. A helpful rule of thumb when you describe what you see and feel: swollen but soft and tender tonsils usually point toward inflammatory or infectious causes, conditions more likely to improve with medical management. Firm, hard, painless swelling, particularly when unilateral, raises a different set of possibilities that require earlier assessment. How tonsil size can shrink: plausible mechanisms of reversal. When people talk about tonsils getting smaller again, they mean measurable reduction in bulk or in the degree of obstruction or visibility. These are the common pathways through which that can happen, carefully framed and without guarantees. 1. Resolution of acute or chronic inflammation. Mechanism: remove the trigger, a resolving infection, appropriate antibiotics when bacterial infection is confirmed, or anti-inflammatory measures, and the immune-driven swelling subsides. Expected timeline: acute improvement can be seen in days. More durable reduction often needs weeks of symptom control. Limitations: if infections recur frequently, the tonsils may remain persistently larger despite repeated short-term regressions. 2. Treating contributing conditions: allergies, sinus disease, reflux. Mechanism: address the ongoing source of irritation so the tonsils are no longer continually stimulated to swell. For example, controlling allergic rhinitis with antihistamines or nasal steroids can reduce lymphoid activity in the throat. Expected timeline: typically weeks to months for steady improvement, sometimes longer. Limitations: underlying susceptibility varies. Some people maintain mild enlargement despite good control of triggers.
3. Removal of retained debris and targeted crypt therapy. Mechanism: if tonsil presence seems bulky because of deep crypts packed with debris or recurrent stones, removing the debris and smoothing the surface reduces apparent size and the sensation of a lump. Some ENT treatments like in-office cryptolysis or laser smoothing are designed for this. Expected timeline: symptom relief can be immediate after in-office cleaning. Structural reduction after a procedure has the healing timeline of any minor procedure, day to weeks. Limitations: these are targeted options selected by an ENT after examination. They're not first line for every case. 4. Spontaneous fluctuation. Mechanism: tonsillar tissue can vary naturally with periods of low and high immune activity. Mild lymphoid hyperplasia sometimes regresses on its own. Expected timeline: weeks to months, unpredictable. Limitations: because this is unpredictable, clinicians often prefer a timed trial of conservative measures rather than assuming spontaneous improvement. 5. Surgical reduction or removal. Mechanism: partial or full tonsillectomy definitively reduces tonsillar bulk and resolves crypt-related problems in refractory cases. Expected timeline: immediate anatomical reduction with a defined recovery period. Limitations: surgery carries risks and is reserved for clear indications such as recurrent severe infections, significant airway obstruction, or persistent symptomatic cryptic disease that does not respond to conservative or in-office measures. What you can try safely at home: conservative measures to reduce inflammation and irritation. Below are practical, low-risk actions that may help reduce tonsillar swelling or at least limit aggravating factors. These are conservative strategies, supportive steps that often accompany definitive care or a clinician's plan. Saline gargles: dissolve half a teaspoon of salt in an 8-ounce glass of warm water and gargle gently several times a day. This helps rinse mucus and can reduce local irritation. It's not a cure, but is safe and commonly recommended. Hydration. Moist mucosa is less irritated. Aim for adequate fluid intake and avoid excessive caffeine or alcohol if they dry your throat. Avoid aggressive manipulation. Do not use cotton swabs, fingernails, or sharp objects to dig at the tonsils. This risks injury, bleeding, and infection. Oral hygiene. Brush, floss, and consider tongue cleaning. Reducing bacterial load in the mouth lowers the material that can enter tonsillar crypts. Manage reflex triggers. If you have reflex symptoms, lifestyle steps, smaller meals, avoid late-night eating, elevation of the head of bed, and clinician-prescribed therapy can reduce throat irritation. Allergy control. If allergies are a trigger, nasal steroid sprays, antihistamines, and avoiding known allergens can decrease lymphoid stimulation. Avoid smoking and reduce exposure to irritants. Tobacco and strong airborne irritants perpetuate inflammation.
Document what you try. A short log. Keep a brief symptom and treatment diary. Record dates, intensity, mild, moderate, severe, what you tried, e.g. saline gargle twice daily, and any associated symptoms. This log is one of the most helpful things you can bring to a clinician. It tells them what you've already attempted and whether there was any response. When to call your clinician. A practical triage timeline. A pragmatic approach often used in clinics is a staged trial. For non-severe, non-red flag presentations, try conservative measures for a short period and reassess. A commonly used timeline in primary care practice. Immediate, first 48 to 72 hours. Home measures like saline gargles, hydration, and symptom documentation. If severe pain, high fever, or breathing difficulty occur, seek urgent care. Short follow-up, about 1 to 2 weeks. If symptoms persist or are recurrent despite conservative steps, contact your PCP for evaluation or a referral to ENT, depending on the pattern. ENT referral. Earlier if there is one-sided enlargement, progressive change, significant airway impact, sleep-disordered breathing, choking episodes, recurrent severe infections, or concerning systemic features. What clinicians will often look for, and which tests they may suggest. Primary care clinicians and ENTs each bring different tools to the diagnostic pathway. Primary care visit. The PCP will review your symptom log, perform a focused throat exam, check for fever or systemic signs, and review medications that could dry the mouth or aggravate reflux. They may start conservative therapies or refer to ENT. ENT evaluation. An otolaryngologist will perform a more detailed oral and neck exam and often a flexible nasal endoscopy to check postnasal anatomy and the upper airway. This helps identify postnasal drip, adenoid tissue, or structural causes affecting the tonsils. Imaging such as CT is reserved for specific suspicions like deep infection, significant sinus disease, or if anatomic detail is needed. Blood tests or targeted biopsies are rare and reserved for concerning atypical findings. In-clinic procedures. Some ENTs perform in-office cleaning of tonsillar crypts, cautery-based smoothing, or limited reductions under local or general anesthesia. Tonsillectomy is reserved for clear indications and follows shared decision-making about benefits and risks. 3 short vignettes to illustrate common pathways: realistic, anonymous, and representative. Case A. Inflammation-driven improvement. You're in your early 30s and notice your tonsils seem puffier than they used to be. There's a recurring sore throat every few weeks, but no high fevers. After a 2-week trial of saline gargles, improved hydration, and a short course of a clinician-prescribed antibiotic for a documented bacterial flare, your tonsils decreased in size and your throat felt less obstructed.
Over several months, with allergy control and occasional saline rinses, the swelling settled further. This illustrates a typical inflammation-driven, partially reversible course, not a guaranteed outcome, but a common one. Case B. Cryptic prominence and targeted ENT care. A patient reports a persistent sensation of something stuck and frequent bad taste. On mirror inspection, there are deep tonsillar pits with visible debris. Conservative measures helped a bit, but symptoms returned. An ENT performed an in-office cleaning and discussed cryptolysis to reduce the depth of the pits. After the in-office procedure and a few weeks of healing, the sensation improved and the tonsils looked less bulky. This highlights how structural crypts can cause apparent enlargement and how targeted procedures can change the surface shape and symptom burden. Case C. Persistent unilateral enlargement that needs investigation. Someone in their 40s notices one tonsil is clearly larger and harder than the other, with no improvement after 2 weeks of conservative care. There are no signs of acute infection, but the asymmetry and firmness are concerning. The clinician refers for a prompt ENT evaluation, flexible laryngoscopy, and targeted imaging. This example shows when earlier referral is warranted to rule out less common but important causes. 2 short clinician scripts to bring to your visit. For a PCP appointment. I've had enlarged tonsils for a duration. I tried saline gargles, hydration, and stopped smoking for 2 weeks with no improvement. I have list symptoms: sore throat, difficulty swallowing, bad taste, snoring. I'd like an assessment and advice on whether I need ENT referral or testing. For an ENT referral request, my tonsils have been enlarged for duration. I've documented symptoms in this log. Conservative measures tried: saline gargles, oral hygiene, reflux precautions, and list meds. I'm concerned about asymmetry, airway symptoms, recurrent infection, and I'd appreciate a nasal endoscopy and discussion of in-office options or further imaging if needed. Begin to weigh expectations, timelines, and realistic outcomes. If your enlargement is mainly inflammatory, expect potential shrinking over days to weeks once the trigger is controlled. If the problem is deeper cryptic change or structural scarring, improvement may require ENT-directed cleaning or procedures and healing over weeks. If allergies or reflux are major drivers, anticipate a slower course. Consistent control over several weeks to months is often required to see meaningful reduction. What we haven't fully covered yet, and what comes next. So far, we've established how to safely look and gather evidence. The common causes of adult tonsillar enlargement, conservative measures that are low risk and often helpful, basic timelines, and who to see. We've also seen representative cases illustrating the range from conservative improvement to the need for ENT intervention.
There are a few important areas that need deeper unpacking before we close this chapter. The specifics of ENT in-office procedures and their typical outcomes and risks, a clearer decision map for when surgical tonsillectomy is seriously considered, the full list of red flag signs that require immediate care, and a practical step-by-step script you can follow in the 48-hour to 2-week trial period, so your clinician has everything needed for a rapid, evidence-based plan. Those topics will help turn the symptom log you started into a structured plan and will make any ENT visit far more efficient, which is exactly what most clinicians prefer. For now, if you've been keeping notes while listening, you're already ahead. The documentation and the 2 short scripts above will make a factual, decisive case at your next appointment. Before we pause and take the next step, one safety point to repeat. Do not attempt sharp or forceful removal of tonsillar tissue at home. Avoid digging into crypts with any object. That can cause bleeding, infection, or scarring that makes the problem worse. We've reached a natural crossroads. You've learned how to check what most likely is causing enlargement after puberty and which conservative measures commonly produce measurable shrinkage. The next section will walk through the ENT-focused assessment and the in-clinic options in greater depth, so you'll understand what an ENT is evaluating during endoscopy, what in-office procedures actually do, how surgical decisions are made, and exactly when urgent care is recommended. An ENT-focused assessment, what to expect and why it matters. When you do decide to see an ENT, or your primary care clinician refers you, the evaluation is about 2 things. First, to identify the most likely driver of the enlargement you've been tracking. Second, to match that driver with an appropriate, proportionate plan, often starting with conservative measures and escalating only when clearly indicated. Here's a practical walkthrough of what an ENT is likely to do, what the findings mean, and how those findings change the plan. 1. The focused history and review of your symptom log. An ENT visit typically begins with a concise history. Your symptom log, the dates, symptom severity, what you tried, and any partial responses, is one of the most helpful items you can bring. Expect the clinician to ask when you first noticed the change and whether it was sudden or gradual, whether the enlargement is constant or fluctuates with illness, allergies, or reflux symptoms, any associated systemic symptoms, fever, weight loss, night sweats, unilateral findings, or new voice or airway symptoms, a review of prior treatments and their effect, antibiotics, steroid sprays, reflux meds, allergy meds, saline rinses. Because you already documented this, the ENT can often avoid redundant steps and focus on targeted exam and tests.
Detailed oral and neck exam. The ENT will perform a careful inspection of the oropharynx and palpation of the neck. Key observations include symmetry versus asymmetry, surface changes, ulceration, exophytic lesions, visible pus or debris, surface scarring, and whether the tissue feels soft/tender or firm/non-tender. Neck palpation checks for associated lymph node enlargement that might suggest regional infection or systemic disease. Flexible nasal endoscopy. Why it's commonly used. Flexible nasal endoscopy is a quick office procedure where a thin, flexible scope is passed through the nose to visualize the upper airway, adenoid area if present in adults, posterior nasal passages, and the larynx. It's particularly useful because it reveals posterior nasal drainage, postnasal drip, that can chronically bathe the tonsils in mucus, contributing to persistent irritation. It shows adenoidal remnants or other upper airway anatomy that can affect airflow and throat irritation. It helps the ENT assess whether airway space is compromised by tonsillar bulk relative to other structures. The procedure is typically well tolerated and provides immediate visual information that guides whether imaging or other tests are necessary. When imaging or laboratory tests are considered, most routine cases do not require CT or MRI. Imaging is reserved for targeted reasons: suspected deep neck abscess, concern for significant sinus disease contributing to chronic postnasal drip, or if there is asymmetric, unexplained enlargement with suggestion of an infiltrative process. Blood tests, CBC, inflammatory markers, or serologies may be ordered if systemic infection or immune-related causes are suspected. Biopsy of tonsillar tissue is rare, but may be considered if there is a suspicious lesion or asymmetry that cannot be explained clinically. In-clinic interventions the ENT might offer. If debris, tonsilloliths, or surface inflammation is evident, many ENTs will offer in-office cleaning and debridement. These are clinician-performed, controlled procedures that aim to remove superficial material, reduce local irritation, and give you immediate symptomatic relief. Possible in-office options include gentle curettage or suctioning of debris and cautery-based smoothing of crypts. These interventions are focused, limited, and typically described as options when conservative measures have not fully relieved symptoms. Procedures beyond in-office care. For patients whose symptoms or anatomy warrant more definitive intervention, the ENT may discuss cryptolysis or surface ablation, targeted procedures to reduce the depth of tonsillar pits and lessen debris accumulation. These may be done in-office or in a minor procedure setting depending on technique and patient comfort. Intracapsular or partial tonsil reduction, a more limited surgical approach that reduces tonsillar bulk but leaves a thin rim of tissue.
It has become an option in some practices for obstructive symptoms, with possibly less postoperative pain and bleeding than full removal, but indications and techniques vary. Traditional tonsillectomy, complete removal, is definitive anatomical removal of the tonsils and the only option that eliminates tonsillar tissue entirely. It's considered when clear indications exist: recurrent severe infections, obstructive sleep-disordered breathing with tonsillar hypertrophy, or refractory cryptic disease causing significant quality of life issues, or when malignancy must be excluded and definitive tissue sampling is required. All procedural options are discussed in a shared decision-making format. Benefits, expected symptom trajectory, recovery timeline, and risks are weighed against conservative options. A realistic decision map for when surgical removal is considered. Surgery is not a first-line solution for most adults with enlarged tonsils. The decision to recommend tonsillectomy or more invasive interventions balances several factors: pattern and frequency of infections that are clearly attributable to the tonsils and that impair daily life despite appropriate medical therapy; airway compromise or sleep-disordered breathing clearly linked to tonsillar size, especially when it reduces sleep quality, causes daytime symptoms, or is associated with objective measures of obstruction; persistent symptomatic cryptic disease or recurrent tonsillolith formation that fails to respond to conservative and in-office measures and leads to ongoing halitosis or discomfort; asymmetric or firm tonsillar enlargement suspicious for neoplastic disease where tissue diagnosis is necessary. Each of these is considered in the context of your overall health, anesthesia risk, and personal preferences. Because adult recovery from tonsil surgery tends to be more uncomfortable than pediatric recovery and carries specific bleeding risks, the threshold for recommending surgery is appropriately cautious. The choice of procedure, partial versus complete, depends on the goals: volume reduction and airway improvement versus complete removal of cryptic tissue, and on the ENT's expertise and available resources. Outcomes and timelines after ENT-directed interventions. In-office cleaning or cryptolysis, many patients experience immediate symptomatic relief, less sensation of something stuck, reduced bad taste, and less throat irritation. Surface healing occurs over days to a few weeks. Targeted partial reduction/smoothing. These can lead to marked symptom improvement with a recovery window measured in days to weeks. Full stabilization of tissue contour may take several weeks.
Intracapsular or traditional tonsillectomy, anatomical resolution is immediate, but pain, difficulty swallowing, and dietary limitations can last for days to weeks. Some people report significant improvement in sleep or infection frequency within weeks, while full recovery of comfort and return to normal activity commonly takes several weeks. Expect follow-up appointments to ensure there is no post-operative bleeding or infection. Across all options, clinicians use the same language we've used throughout. Outcomes vary, and while many patients see meaningful reduction in size and symptoms, there are no absolute guarantees. A practical, step-by-step 48-hour to 2-week trial you can follow at home. If you're starting conservative care at home before a PCP or ENT visit, here's a concise, scripted routine that mirrors what many clinicians find efficient. Follow this plan unless you have red flag symptoms that require immediate evaluation. Day 0. Start. Begin a symptom log. Note the date and time, what you feel, throat pain scale 0 to 10, swallowing difficulty, breathing or sleep changes, smell, taste changes, and whether the swelling looks different in a mirror photo.
If you're comfortable, take one clear, well-lit photograph of your oropharynx for reference. Do not attempt deep inspection or instruments. Start saline gargles. Warm salt water, about half a teaspoon of salt and 8 ounces of warm water. Gargle gently and spit out, 3 to 4 times per day. Hydration and voice rest. Sip water regularly. Avoid yelling or straining your throat if painful. Review reflux precautions. Avoid large meals late at night, reduce alcohol and caffeine for a short trial, and sleep with head elevation if reflux is an issue. Adjust environmental factors. If you smoke, reduce or stop. Reduce exposure to known irritants. First 48 to 72 hours. Continue saline gargles and hydration. Note any improvement in pain, drainage, or lump sensation. If you have systemic symptoms, fever or severe pain, or if swelling seems rapidly worse, contact your clinician immediately rather than waiting. Avoid any attempts to remove material from your tonsils yourself. No probing, no cotton swabs, no forceful actions. Days 3 to 14. Continue the log. If you notice improvement, reduced pain, less drainage, softer feel, keep current measures and plan for a PCP follow-up at about 1 to 2 weeks if symptoms persist. If minimal or no improvement by day 7 to 14, call your PCP for an appointment or ask for an ENT referral. Attach your log notes to the appointment scheduling message or portal entry if you can. If you experience recurrent episodes over weeks or months despite these measures, consider requesting direct ENT evaluation. What to document during the trial? In efficient symptom entry format. Write short entries. Clinicians appreciate clarity and brevity. For each entry include date, key symptoms, and weather.
Sore throat, 4 out of 10. Difficulty swallowing solids, bad taste. Visible findings, mirror photo taken, yes, no. Actions tried, saline gargle X3 day, OTC analgesic, reflux precautions. Response, improved, worse, no change. This format keeps the record actionable and helps clinicians see patterns quickly. Red flags that require urgent or same-day evaluation. Seek immediate medical attention or a same-day ENT or urgent care visit if you have any of the following: rapidly enlarging tonsillar mass or sudden worsening in a short period, difficulty breathing, noisy breathing, or stridor, high-pitched breathing sounds, inability to swallow saliva or excessive drooling, severe throat pain with high fever or signs of spreading infection, neck swelling, rapidly increasing pain, significant bleeding from the throat or new blood in saliva, unexplained weight loss, persistent night sweats, or a firm, painless unilateral tonsillar mass. These signs suggest complications or less common causes that need prompt diagnostic evaluation and, in some cases, urgent intervention. 3 refined vignettes with timelines and clear outcomes. We introduced representative cases earlier. Here are expanded versions focusing on timelines and decision points so you can map your own situation to a likely pathway. Vignette 1. Inflammatory, responsive within weeks. You're in your late 20s and notice a gradual increase in throat clearing and a muffled feeling at the back of your throat after a long season of allergies. You start the 48-hour trial. Saline gargles, nasal steroid spray for allergies as recommended by your PCP, and reflux precautions. Within 5-7 days, the soreness reduces and the sensation of bulk diminishes. At 2-week follow-up, you and your clinician decide ongoing allergy control and intermittent saline rinses are a reasonable maintenance plan. Timeline, days to noticeable improvement, weeks to stabilization. Vignette 2. Cryptic disease leading to ENT in-office solution. A patient in their 30s has recurrent bad taste and visible tonsil stones on mirror inspection despite good oral hygiene. The 48-hour trial shows little change beyond temporary relief after gargles. The PCP refers to ENT. The ENT performs in-office cleaning and discusses cryptolysis as an option. After a minor procedure and 2 weeks of healing, the tonsils and bad taste dramatically reduce. Timeline, short conservative trial, ENT in-office intervention, immediate symptomatic relief, weeks, surface healing, and sustained improvement. Vignette 3. Asymmetry firmness requiring prompt workup. Someone in their 40s noticed that one tonsil seems much larger and feels hard. Conservative measures over 2 weeks produce no change. Systemic symptoms are absent, but asymmetry and firmness are concerning. The PCP refers urgently to ENT. The ENT performs flexible endoscopy and arranges imaging and biopsy as indicated.
The workup uncovers a localized, non-infectious process requiring specialist care. Timeline, immediate referral after short trial, targeted imaging/biopsy, definitive diagnosis and treatment planning. Clinician scripts you can bring. Short, ready-to-use lines. Bring these short scripts in writing or paste them into a message to the clinic when requesting an appointment. They save time and focus the visit. For your PCP, brief. I've had visibly enlarged tonsils for duration. I completed a 48-hour conservative trial, saline gargles, hydration, reflux precautions, and allergy steps with no meaningful improvement. Symptoms, list, sore throat, difficulty swallowing, bad taste. I'd like an assessment and, if appropriate, an ENT referral for endoscopic evaluation. For an ENT referral request or message, tonsillar enlargement for duration with attached symptom log and mirror photos. Conservative measures tried: saline gargles, oral hygiene, reflux precautions, allergy therapy. Key concerns: asymmetry, airway symptoms, recurrent stones. Please evaluate with flexible nasal endoscopy and advise on in-office options or imaging if indicated. Documentation and test order tips that help clinicians act faster. Attach a concise symptom log and up to 2 mirror photos with your appointment request. These materially speed up triage decisions. List current medications, including inhalers, nasal sprays, OTC antihistamines, and any recent antibiotics. These can alter the differential. Note allergies, smoking history, and reflux history succinctly. If you've had prior ENT visits or throat surgeries, bring prior operative notes or summaries if you have them. This little organizational effort on your part often reduces duplicate testing and makes the appointment more productive. Common questions people ask about risks, recurrence, and long-term outlook. Will tonsils come back after partial removal? Partial or intracapsular techniques leave some tissue, and thus can theoretically allow tissue regrowth or recurrence of minor symptoms, though many patients get long-lasting relief. Exact durability depends on the technique and individual biology. If I have tonsillectomy, does it completely eliminate infection risk? Removing tonsils removes that specific tissue as a reservoir, which often reduces throat infection frequency when the tonsils were clearly the source. However, pharyngitis from other causes can still occur. Does surgery eliminate tonsil stones or bad breath? Removing or substantially reducing tonsil outage lead to tonsillitis improves markedly after appropriate ENT intervention. All answers should be discussed with your clinician, who will frame likely outcomes against your individual pattern of symptoms.
Practical safety reminders we can't repeat too often. Never attempt to remove tonsillar tissue or embedded stones with sharp instruments or by force. This can cause bleeding, infection, and scarring that makes the problem worse. Avoid abruptly stopping prescribed medications with clinician guidance. Some drugs affect reflux or immune response and should be adjusted under supervision. If you have significant bleeding or airway compromise symptoms, seek emergency care immediately. These are not conditions to monitor at home. A small FAQ to cover common uncertainties. Q. How long before I know a conservative trial has failed? A. A pragmatic approach is 7 to 14 days for many non-severe cases. If limited improvement is seen early, but symptoms are recurrent or impactful, seek an earlier clinician review. If you have red flag signs, don't wait. Q. Can allergies alone make tonsils stay large in adults? Yes. Chronic allergen exposure can maintain lymphoid hyperplasia. Effective allergy control can reduce size over weeks to months in many, but not all individuals. Q. Are there home devices that safely clear tonsil debris? Gentle saline gargling and good oral hygiene are the safest home measures. Devices or tools that penetrate crypts should be avoided unless used by an ENT in a controlled setting. Q. What is the typical pain after tonsillectomy for adults? Adult postoperative pain is often more pronounced than in children and commonly requires a planned analgesic strategy discussed with your surgeon. Recovery timelines vary. Most people need several days of rest and progressive return to normal diet and activity over 1 to a few weeks. Final guidance on setting expectations and next steps. You've now seen how an ENT approaches enlarged tonsils after puberty. Careful history and documentation, targeted exam with endoscopy when indicated, conservative trials, selective in-office procedures, and surgical options reserved for defined scenarios. Most importantly, the path to meaningful reduction starts with clear documentation, a short conservative trial if safe, and timely clinician involvement when improvements are not seen, or when red flags appear. Before we close, here's a short practical checklist you can use immediately. Start a daily symptom log with at least 1 mirror photo if you can take it safely. Begin the 48-hour conservative trial. Saline gargles, hydration, reflux precautions, and limit irritants. If no meaningful improvement in 7 to 14 days, schedule a PCP visit and paste the brief PCP script above into the appointment request. If you have any red flag signs at any time, seek urgent care. One closing, focused call to action. If your tonsils have been persistently large, asymmetric, or you've had recurrent symptoms despite conservative care, use the clinician script above and schedule an evaluation with your PCP or ENT. Bring your log and photos. They make the visit faster and the plan clear.
If you found this guidance helpful, check the description for a short demo on safe mirror inspection and saline gargles that you can use during your 48-hour to 2-week trial. Take the notes with you and let your clinician help decide which of the pathways we discussed is the right next step for you. You don't have to guess at this alone. With focused documentation, a short conservative trial, and the right specialist input when needed, many causes of post-pubertal tonsillar enlargement are diagnosable and often manageable, and in many cases, size can decrease once the underlying driver is identified and treated.